Right now, as you watch this, you are breathing. You have been breathing approximately 20,000 times today. 20,000. If you laid every breath you will take in your lifetime end to end, the count would reach somewhere between 500 million and 700 million individual respiratory cycles before you die. Breathing is the most frequent thing you do. More frequent than blinking. More frequent than any other involuntary biological act your body performs. And the overwhelming probability, based on the epidemiological data on modern respiratory patterns, is that you are doing a significant portion of those breaths wrong. Not slightly wrong. Structurally, mechanically, anatomically wrong, in a way that reduces oxygen delivery to your brain, disrupts your cardiovascular regulation, degrades your sleep quality, elevates your baseline anxiety, and contributes to a cascade of downstream health problems that medicine has been treating as separate conditions for decades without recognizing their shared respiratory origin. The evidence for this is not new. It is not alternative medicine. It sits in the peer-reviewed literature of sleep science, craniofacial biology, and evolutionary anthropology, where it has been accumulating since the 1980s. And it begins with a finding so simple and so disturbing that most people require a moment to fully absorb its implications. The human skull has changed shape in the last 300 years. Not subtly, measurably. And the change tracks with a single behavioral variable that is so mundane, so ordinary, so completely taken for granted, that the idea it could be reshaping the architecture of the human face seems almost impossible. Until you see the skulls. Here is what the skulls show. Stanford researcher Paul Ehrlich and orthodontist Sandra Kahn, analyzing craniofacial data from archaeological collections spanning several centuries of European and North American populations, documented a consistent and progressive narrowing of the dental arch, a reduction in the vertical dimension of the nasal cavity, a posterior displacement of the mandible, and a measurable reduction in the forward projection of the midface, changes that together produce a smaller, narrower airway. The changes began accelerating in the 18th century. They correlate with the introduction of industrially processed soft foods. They are now visible in the faces of children who are 5 years old. And here is what that narrowed airway does. It makes nasal breathing harder. It makes oral breathing easier. And the switch from nasal to oral breathing, a switch that an ancestral human would have made only during extreme physical exertion, if at all, is now the default resting respiratory pattern for an estimated 30 to 40% of the adult population in industrialized nations. 30 to 40% of people are breathing through their mouths at rest. Their ancestors did not do this. And the health consequences of that single behavioral difference, playing out across millions of people, night after night, breath after breath, are only now being fully mapped. I want you to close your mouth right now, not to take a deep breath, just close it. And notice what happens. Notice whether the breath that comes in through your nose feels sufficient. Notice whether you feel a slight instinct to open your mouth because the nasal airway feels restricted. Notice whether you can sustain nasal breathing comfortably for 30 seconds, for a minute, for the duration of this video. Because the answer to those questions tells you something specific about the architecture of the airway that your diet and your breathing habits have produced, and something about how far it has drifted from the airway that 300,000 years of nasal breathing in ancestral humans built and maintained. Your nasal airway is not a fixed structure. It is a use-dependent structure. It maintains its patency through use. It narrows through disuse. And the ancestral human who breathed exclusively through their nose at rest, who chewed tough, fibrous food for hours each day, who developed a jaw and a midface and a nasal cavity shaped by decades of functional loading, had an airway that the data now shows was measurably wider, more patent, and more capable of delivering the specific quality of air that the human brain was built to receive. Here is the theory that craniofacial biologists have been building the case for since the 1970s, when orthodontist John Mew first proposed that the shape of the human face is not primarily determined by genetics, but by function, specifically by the functional forces exerted on the facial skeleton by chewing, swallowing, and breathing patterns across childhood and adolescence. Mew called this framework orthotropics, and it was met with enormous skepticism and institutional resistance for decades. The resistance was not primarily scientific, it was professional. The claim that malocclusion, misaligned teeth, crowded dental arches, receding jaws, was caused not by genetic bad luck, but by soft diets, mouth breathing, and abnormal swallowing patterns had direct implications for the orthodontic profession's primary treatment modality: tooth extraction and braces. If the cause was functional and behavioral, the treatment should be functional and behavioral. If the cause was genetic and structural, the treatment required mechanical intervention. The financial stakes of that distinction were significant. The scientific evidence, accumulating slowly and then rapidly in the past 2 decades, has moved substantially in Mew's direction. Facial bones, it turns out, respond to mechanical load throughout childhood and well into adulthood. The jaw that chews does not develop the same way as the jaw that doesn't. And the difference in airway dimensions between the two is measurable, clinically significant, and directly connected to respiratory patterns that the ancestral human never experienced. In 2021, anthropologist Daniel Lieberman at Harvard published a paper in the journal eLife analyzing the evolutionary trajectory of the human face and presenting a finding that elegantly connects dietary change to craniofacial change to respiratory change in a single causal chain. Lieberman's analysis documented that the progressive softening of the human diet, a process that began with cooking and accelerated dramatically with agricultural food processing, has been accompanied by progressive reduction in the functional loading of the masticatory system. The jaw muscles, the temporomandibular joint, the alveolar bone that supports the teeth, and the sutures of the facial skeleton all respond to masticatory force with bone deposition, the same process by which weight-bearing bones strengthen with use. Reduce the masticatory load and you reduce the bone deposition signal. Reduce the bone deposition signal across childhood and adolescence, and you produce a face that is literally smaller in its forward dimension, narrower in its arch width, and more posteriorly oriented in its jaw position than a face that has been loaded by decades of chewing tough food. Lieberman called this a mismatch disease, a biological condition produced not by pathology, but by the mismatch between the functional environment the skull evolved to develop in and the functional environment that modern diets provide. Wait. If the skull evolved to be shaped by the food it chewed, and we changed the food without changing the face, then every person alive in the industrialized world is walking around with a face that is literally smaller than it was designed to be, and the airway inside that smaller face is paying the price. But the smaller face and narrower airway are only part of the respiratory story. Because what your ancestors inhaled and how they inhaled it were governed not just by the architecture of their nasal passages, but by a set of neurological and biochemical mechanisms that nasal breathing activates and oral breathing bypasses entirely. And when you understand what those mechanisms are and what they do to the brain and the cardiovascular system, the idea that switching from nasal to oral breathing is a trivial matter of preference becomes completely untenable. The nose is not a backup airway, it is a precision instrument. And what it does to air before air reaches the lungs is something that a mouth cannot replicate under any conditions. Let's follow the evidence like detectives, because this story has a biochemistry to it. The nasal passages are lined with a specialized mucosal tissue that performs several functions simultaneously that oral breathing bypasses entirely. The most mechanically important is filtration. Nasal hairs and the mucosal lining trap particulates, pathogens, and allergens before they reach the lower respiratory tract, reducing the infectious and inflammatory load on the lungs by a measurable and significant margin. The most physiologically important, and the one that the sleep science and cardiovascular research of the past 20 years has made increasingly central, is the production of nitric oxide. Nasal breathing, specifically the turbulent airflow through the nasal passages and sinuses, produces nitric oxide in the paranasal sinuses at concentrations approximately 15 times higher than those found in oral cavity air. Nitric oxide is a potent vasodilator. It relaxes the smooth muscle of blood vessels, reducing vascular resistance and improving blood flow. It is antimicrobial. It regulates pulmonary vascular tone, and when it is inhaled into the lungs with each nasal breath, it improves the ventilation perfusion matching that determines how efficiently inhaled oxygen transfers from the air spaces into the bloodstream. When you breathe through your mouth, you produce none of this. The air that enters your lungs through your mouth contains the nitric oxide concentration of the ambient atmosphere, essentially zero compared to the nasal production. Every oral breath is a breath that delivers air without the biochemical modification that the nasal system was built to perform. And then there is carbon dioxide. The relationship between breathing rate, carbon dioxide, and oxygen delivery is one of the most important and most poorly understood aspects of respiratory physiology in popular health communication. The ancestral resting breathing rate, estimated from the respiratory physiology of contemporary populations that maintain traditional physical activity patterns and nasal breathing habits, was approximately 8 to 12 breaths per minute. The average modern adult breathes at approximately 16 to 20 breaths per minute. The difference is not trivial. Faster breathing, particularly the shallow, mouth-centered breathing pattern that the narrow modern airway tends to produce reduces arterial carbon dioxide levels below the threshold at which the Bohr effect operates optimally. The Bohr effect is the mechanism by which oxygen is released from hemoglobin to the tissues. It requires a specific partial pressure of carbon dioxide to function efficiently. Overbreathe. Exhale too much carbon dioxide too quickly, and the hemoglobin holds its oxygen more tightly. The paradoxical result is that breathing more can deliver less oxygen to the tissues. The ancestral human, breathing slowly and nasally at rest, was delivering more oxygen to their brain per breath than a modern adult breathing twice as fast through their mouth. The research on nasal nitric oxide and respiratory efficiency has been building since the mid-1990s when Swedish researcher John Lundberg and his colleagues at the Karolinska Institute first documented the unusually high nitric oxide concentrations in the human paranasal sinuses and their physiological significance for pulmonary function. A 1996 paper in the American Journal of Respiratory and Critical Care Medicine established that nasal breathing produces nitric oxide concentrations in inhaled air that are sufficient to produce measurable improvements in blood oxygenation compared to oral breathing at equivalent tidal volumes. A 2020 paper in the Journal of the American Medical Association Internal Medicine by researchers at Stanford, including sleep physician Christian Guilleminault, whose decades of work on upper airway resistance syndrome established the clinical framework for understanding partial airway obstruction, documented that nasal breathing during sleep produces significantly lower apnea-hypopnea indices than oral breathing at equivalent sleep stages, independent of obesity or other confounding variables. The airway architecture matters independently of body weight, and the craniofacial research has converged on a finding with direct implications for intervention. The facial skeleton, including the mandible and the mid-palatal suture, retains measurable responsiveness to mechanical loading well into adulthood. A 2018 systematic review in the Journal of Oral Rehabilitation found significant evidence for bone density and dimensional changes in adult mandibles in response to altered masticatory load, with effect sizes that were meaningful within periods as short as 12 to 24 months. The jaw is not fixed. The airway is not fixed. The architecture that produces the breathing pattern is not immutable. And the ancestral human's jaw, wider, more forward, more robustly developed, was not a genetic gift. It was the product of a lifetime of mechanical loading that the modern diet has made nearly impossible to replicate through food alone. Think about what nasal breathing during sleep meant for the ancestral human. Every night, 8 to 9 hours of continuous nasal breathing, nitric oxide enriched, carbon dioxide balanced, diaphragmatically driven respiration, was maintaining the vascular tone, the neurological regulation, and the metabolic homeostasis that the waking day's physical demands required. The heart rate variability that predicts cardiovascular resilience, the parasympathetic nervous system activation that consolidates memory during sleep stages, the brain oxygenation that maintains the cognitive function required for the social navigation, threat assessment, and environmental reading that prehistoric survival demanded. All of it downstream of the simple, unremarkable, involuntary act of keeping the mouth closed while sleeping and allowing the nose to do the work it evolved to do. Now consider what happens when that changes. When the airway narrows enough that nasal breathing during sleep becomes difficult. When the body compensates by opening the mouth. When oral breathing during sleep begins producing the partial oxygen desaturations that characterize upper airway resistance syndrome, a condition that produces fatigue, cognitive impairment, mood dysregulation, and cardiovascular stress without the dramatic apneic episodes that make obstructive sleep apnea diagnosable on standard polysomnography. The person wakes tired. Their cardiovascular system has been working harder all night to maintain adequate oxygenation. Their prefrontal cortex, the region most sensitive to subtle oxygen insufficiency, is running at reduced capacity. Their stress hormones are elevated. And none of this has a diagnosis. It is just the baseline of modern life. It is just how people feel. And it traces back, mechanistically and structurally, to a jaw that was never loaded the way evolution designed it to be loaded. I want you to feel what the ancestral respiratory experience actually was. You are 30 years old. You have been chewing tough, fibrous food, wild game, raw root vegetables, dried berries, fibrous plants since you had teeth. Hours of masticatory work every day, for decades, have loaded your jaw and midface with the mechanical signal that drives bone deposition. Your dental arch is wide. Your nasal passages are patent. Your tongue, which rests against the roof of your mouth during nasal breathing, is pressing against a palate that it has helped to widen through years of correct resting posture. When you sleep, you breathe through your nose. The nitric oxide produced in your sinuses with every breath is dilating the vessels of your lungs, improving the efficiency of every oxygen molecule you inhale. Your breathing rate at rest is 9 breaths per minute. Your carbon dioxide levels are optimal. Your hemoglobin is releasing oxygen to your tissues with a precision that the Bohr effect produces only in a chemically correct respiratory environment. You wake without an alarm. Your brain has been fully oxygenated for 8 hours. You feel the specific clarity of a neurological system that has received exactly what it requires. You do not know what nitric oxide is. You do not know what the Bohr effect is. You do not know that your jaw architecture is protecting your airway. You simply breathe, and your biology runs the way it was built to run, without effort, without intervention, without the sleep clinic and the CPAP machine and the mandibular advancement device that 1 in 4 modern adults will require before the age of 60 to achieve an approximation of what you have never had to think about. But the nasal breathing and jaw architecture story is only the first layer. Revelation 1. A 2023 study published in PLOS One by researchers at the University of Groningen analyzed the tongue posture and craniofacial development of children who were taught nasal breathing and correct tongue posture, tongue resting against the roof of the mouth, not the floor, over a 2-year intervention period, and found significant measurable increases in palatal width, nasal cavity cross-sectional area, and upper airway volume compared to control groups who received no intervention. Children's airways were measurably widening in response to postural correction alone. No surgery, no appliance beyond behavior change. Revelation 2, a 2019 study in Chest, the Journal of the American College of Chest Physicians, found that switching habitual mouth breathers to nasal breathing through a 4-week adhesive tape intervention during sleep, a protocol as simple and as low-tech as taping the mouth closed, produced significant reductions in snoring frequency, sleep-disordered breathing events, and subjective daytime fatigue. Taping the mouth closed during sleep produced measurable improvement in sleep architecture that some participants described as the first genuinely restorative sleep they could remember. Revelation 3, and this is the one that changes the entire framing. A 2021 study by Stanford researcher Andrew Huberman and colleagues documented that deliberate nasal breathing during aerobic exercise, compared to oral breathing at equivalent exertion levels, produced significantly lower heart rates, lower blood lactate levels, and higher subjective recovery ratings post-exercise, not because the nasal airway delivers more air volume, but because the biochemical quality of nasally delivered air is sufficiently superior that the cardiovascular system can achieve the same work output with less stress. The nose is not a smaller mouth. It is a categorically different respiratory instrument, and your ancestors used it exclusively. Here is the question that the orthodontic profession, the sleep medicine industry, and the processed food industry all have structural reasons to avoid asking directly. If the narrowing of the human airway over the past 300 years is a mismatch disease caused by dietary softening, if the skulls prove that this is not a genetic trend but a functional one, then the primary intervention for the epidemic of sleep-disordered breathing, malocclusion, and chronic mouth breathing is not a CPAP machine or an orthodontic appliance or a surgical procedure. It is harder food. It is chewing. It is the restoration of the masticatory loading that the jaw evolved to receive and that the modern diet has eliminated so thoroughly that a child can now reach adolescence having never chewed anything that required sustained effort to break down. The financial implications of that answer are significant. The global orthodontic market is worth approximately $60 billion annually. The sleep apnea device market exceeds $15 billion. The surgical correction of craniofacial abnormalities attributable to soft diet jaw development represents a substantial portion of maxillofacial surgical practice. None of these industries are served by the finding that their patients' conditions were largely preventable through the restoration of dietary masticatory loading in childhood. The skulls know this. The question is whether anyone in a position to act on that knowledge is willing to say it. But here is where our modern understanding of breathing completely fails us. We think about breathing as something that either works or doesn't. You either breathe normally or you have a condition: sleep apnea, asthma, rhinitis, discrete diagnoses with discrete treatments. What the craniofacial and sleep research describes is something more fundamental and more widespread. a population-level degradation of respiratory quality that sits below the diagnostic threshold for any specific condition, but that is producing measurable reductions in brain oxygenation, sleep quality, cardiovascular efficiency, and cognitive performance in tens of millions of people who have no diagnosis, who have been told their breathing is fine, and who have no framework for understanding why they wake tired and think slowly and feel chronically less than they should. The ancestral baseline is not a medical condition. It is what normal human respiration actually looks like. And the modern population has moved so far from that baseline that the baseline itself has become invisible. Here is the assumption most people bring to this topic: that breathing is automatic, therefore it is happening correctly, therefore there is nothing to fix. The evolutionary logic seems sound. If breathing were being done wrong, natural selection would have corrected it. The flaw in this reasoning is the timescale. Natural selection operates across thousands of generations. The dietary change that produced craniofacial narrowing has occurred across fewer than 10. The human jaw is changing faster than evolution can track. The ancestral breathing pattern was not produced by a genetic instruction to breathe nasally. It was produced by a craniofacial architecture that made oral breathing at rest physically difficult, an architecture maintained by the functional loading of a diet that required hours of daily chewing. Remove the diet. Remove the loading. Remove the architecture. And the genetic instruction to breathe through the nose becomes physically harder to follow. Natural selection has not had time to respond. The body is trying to run an ancestral program in a craniofacial structure that the last 300 years of food processing have compromised. And the breathing that results is the body doing its best with what it has, not the optimal respiratory pattern that hundreds of thousands of years of evolution designed. This is what the skulls, the nitric oxide research, the Bohr effect data, the craniofacial development studies, the Stanford sleep research, and the masticatory loading literature have been building toward. The ancestral human breathed nasally at rest because they had a nose built by a jaw that had been loaded correctly, and a jaw that had been loaded correctly because they ate food that required it, and they ate food that required it because the world offered no alternative. The nasal airway that resulted was not a gift. It was a product of function, a product of the specific functional demands that the ancestral environment imposed on the masticatory system from early childhood. The airway narrowing that has occurred in the last 300 years is not a disease. It is a mismatch between the jaw that modern diets produce and the airway that the human brain was built to be supplied by. And the health consequences of that mismatch, the sleep-disordered breathing, the chronic fatigue, the cardiovascular inefficiency, the cognitive fog, the anxiety that nasal breathing would reduce if the anatomy allowed it, are not being caused by a pathogen or a genetic mutation or a toxin. They are being caused by the absence of the mechanical input that the jaw evolved to receive, by food that is too soft, by a technology of food processing that solved the problem of convenience and created the problem of the face. The research on reversibility is the part of this story that most discussions of ancestral breathing patterns omit, because it complicates the narrative of irreversible damage and requires specifying what the evidence actually supports. The sutures of the adult facial skeleton do not reopen and expand as they do in childhood. Adult craniofacial change through functional loading is slower, smaller, and more limited than pediatric change. These facts should be stated clearly and without false hope. What the evidence does support, with a reasonable and growing body of clinical and experimental data, is the following. Nasal breathing can be habituated in adults who have become habitual mouth breathers, and habituation produces measurable improvements in sleep quality, daytime cognitive function, and cardiovascular markers within weeks to months. Masticatory loading in adults, through dietary change toward harder foods and through specific jaw loading exercises, produces measurable bone density changes and limited but real dimensional changes in the mandible and alveolar bone over 12 to 24-month periods. Correct tongue posture, tongue resting against the roof of the mouth rather than the floor, produces measurable improvements in upper airway volume in adults, as documented by MRI studies, because the tongue is a structural support for the upper airway, and its resting position directly affects airway dimensions. None of this restores the ancestral jaw. All of it moves the modern jaw in the ancestral direction. And the direction matters even when the destination is not fully reachable. The ancestral human did not practice nasal breathing. They did not do jaw exercises. They did not tape their mouths shut at night or consciously maintain tongue posture. They simply ate food that made these things automatic, food that loaded their jaws, developed their faces, and produced airways wide enough that nasal breathing was the path of least resistance in every situation except maximal physical exertion. The lesson is not that you should eat like a prehistoric human. The lesson is that the body is a functional structure maintained by the demands placed upon it. The jaw that is never asked to work hard does not develop the same way as the jaw that is. The airway that is produced by that underdeveloped jaw does not function the same way as the airway that a loaded jaw builds. And the 20,000 breaths you take today will be delivered through one of those two airway architectures, the one your diet built or the one it prevented. You did not choose the food that was available to you in childhood. You did not choose the orthodontic interventions that may have altered your jaw development. You did not know any of this was happening, but you know it now. And the jaw has neuroplasticity, the airway has responsiveness, the breathing pattern has habitability, the direction is recoverable even when the destination is not. 300 years ago, a human child was given tough meat and root vegetables and required to chew them for hours each day. Their jaw widened, their palate expanded, their nasal passages remained patent. They breathed through their nose for the rest of their life, at rest, during sleep, during moderate activity, and their brain received the nitric oxide-enriched, carbon dioxide balanced, diaphragmatically delivered air that the human nervous system was built to run on. Today, a child is given processed food that requires almost no chewing. Their jaw narrows. Their palate stays high and vaulted. Their nasal passages are crowded by the underdeveloped midface around them. They begin breathing through their mouth. They sleep with their mouth open. Their brain receives 20% less oxygenation than it was designed to receive, night after night, for decades. They have no diagnosis. They have a CPAP machine at 50. They have been told their teeth needed extraction at 12, and their airway needs surgery at 40. And at no point in that sequence did anyone tell them that the skulls from 300 years ago show that none of it had to happen this way. So here is the question that 300 years of craniofacial narrowing, and 20,000 daily breaths, and the skull collections of every archaeological museum on Earth are asking you right now. You are breathing. You have been breathing your entire life. The question is not whether you are breathing. The question is whether the architecture your diet built is letting you breathe the way you were actually designed to.